why are we not focusing on getting the fundamentals right in the public sector? Why is the governance not being addressed? Why is the corruption not being addressed? Why is the moonlighting not being addressed? Where's the accountability in the system? Because with the resources we have, we can compare with other countries and know that we should be doing much better than we are, but we're not.
National health insurance has been on South Africa's policy agenda for a number of years now. What risk does this pose to our healthcare system? And what potential alternatives could we be exploring instead? Well, somebody who's been spending a lot of time on this is Mike Settas. He is the chair of the Health Policy Unit at the Free Market Foundation, where I will be taking up my new role next year. Mike Settas, welcome to the show.
Well, thank you very much, David, and looking forward to working with you fairly shortly.
Well, yeah, hopefully this is the first of many such conversations. So for those of my audience who are not familiar with national health insurance and the proposal that's been on the table for many years now, what is it exactly? What is being proposed by the Department of Health and the government more broadly? And what are some of the issues that you are flagging?
Yeah, so and it certainly has been on the table for a long time. We're looking at next year will be the 14th year in which this has now been official policy. But the key issues are that it's an exceptionally high-risk proposal, and what it's proposing is to simultaneously amalgamate the public and private health systems into one state-run health system. The concerns that we have around it and in the policy process is that technical feasibility analysis has been pretty much absent. There's no costing analysis on it. I heard recently that in the Health Portfolio Committee that the DA is calling for a financial feasibility study from Treasury and from the Finance Minister to say, how are we supposed to even evaluate this bill, which is now before Parliament, if we have no idea what it's going to cost. So those are some of the concerns. I think they're major concerns, especially with such a massive, far-reaching proposal. But there doesn't seem to be much in the way of addressing those concerns. My sense is that the policy's been driven very much on ideology of just central control of everything. For the private sector, they can pretty much view this as a nationalization of the private sector into the state-run entity, the NHR fund.
All right, so basically this is centralization of all healthcare financing. And I think for the purposes of this conversation, we can distinguish between the funding side and then the operational side of our public healthcare system and also the private healthcare system. But obviously the two will be very much interrelated.
It has fundamentally all been about the funding. The focus of the NHR is not focused on the operational aspects of how to work or whether to address some of the fundamental and substantial problems that exist in the public sector in terms of governance frameworks, in terms of management capabilities, substantial failures that exist. The NHR proposal is really focused only about funding, and with this overarching, I wouldn't maybe call it an ideology, but a sort of belief that if you just throw more money at this thing, it's we're magically going to fix all the problems in the public health system. So the way the NHR is proposing is that the private and public sectors will coexist, but they'll all be under the control of the NHR fund. So the NHR fund will determine for members of the NHR which doctor you'll go to. So if you're close to this doctor and it happens to be a private doctor, you go there. But if you happen to be close to this one and and it's a public doctor, you go there. So essentially, we'd be taking full control of both sectors from a financing point of view. No real talk around how the fundamentals of governance and management of facilities will change.
All right. And anybody who's spent any time in a public hospital will know that it's in quite a dire state. I mean, compared to the rest of sub-Saharan Africa, we actually have quite a well-endowed public healthcare system. But there are numerous perverse incentives in that system, a lot of inefficiencies, a lot of governance problems, and a lack of accountability that has really seen the deterioration of those services. So I mean, it seems to me that this big kind of mega financing plan that's going to essentially crowd out private healthcare funders is not really going to address those key concerns and might actually make them even worse in the public healthcare system.
Yeah, I think it would be hard to believe it could get worse, but I think it could. It would. But yeah, it will definitely crowd out the private funding sector in terms of the NHR taking over all the funding. So it'll be anything that the NHR covers, the medical schemes will not be allowed to insure that service or that benefit. So that is definitely a fundamental of what the proposal is.
Nicholas Crisp, the Deputy Director General in the Health Department, he's saying that both the public and the private sector have issues. I mean, do you think that he is fairly representing the state of healthcare in South Africa?
I think he's absolutely correct that both sectors have problems. The private sector has the fundamental problem the private sector has is cost and inefficiency around that. But to draw an equivalence between them, I think, is an exceptionally large leap or stretch to try and make. By and large, the private sector still functions well in terms of its delivery of care. The quality is high. Waiting periods for any sort of major procedures are pretty much unheard of. People who get major illnesses will access treatment very quickly. Its problem, as I say, is cost, but it still functions. It's still working well. But there are areas in which it can be fixed. And I think the importance of that is that the country has already been given a blueprint for that and has actually paid for it through the health market inquiry, which was run by the Competition Commission over a period of 6 years, which was characterized by an enormous amount of data collection, research, and engagement with stakeholders in terms of what they see the problems are, what could be the solutions to those. And there's a blueprint now, and it sits there in the final conclusions, recommendations of the health market inquiry, but we see absolutely no appetite to engage that and actually implement any of those, because everything's being done in favor of NHR, which is an overarching proposal for both public and private.
All right, so let's look now at some of the mechanics and where we are in terms of the legislation. We have the NHI bill that's before Parliament that's likely to be passed. Do you know anything about timelines there?
I know that the Portfolio Committee is now finished going through the bill clause by clause, and now the position is that there are 12, I think it's 12, there might be 13, but let's call it just 12 for now. 12 other statutes or other acts which are required to change in order to support the NHI bill, or once it becomes the act, NHI Act as such. But that process is an amendment. Each one of those, each one of the 12 is now an amendment to an act, which we believe would have to go through the same parliamentary process with public consultation and engagement that any other act or amendment to an act would have to go. So that's quite a task for that Portfolio Committee to go through that. We haven't seen the meat of those changes either. It's been spoken as to what, in principle, the changes are required, but the meat of it and the details is still not there. So it seems to me that the sort of ambitions of this NHR bill being passed anytime soon is rather ambitious, given that there are at least 12 other pieces of legislation, not regulations. These are acts that need changing in order to support the NHR bill before the NHR bill could become an act. So quite a substantial amount of work.
Okay, but in some respects, that's an opportunity to throw some sand in the gears and slow down the implementation of NHI.
Yeah, well, yes. I mean, it's the point is as well is that a lot of the meat of how things will work lies in that other legislation. So again, the NHI bill has put together a very, very broad framework. It doesn't really get into much detail in any particular area. And the meat of it is really, lies in how it relates to these other pieces of legislation. So, but it is absolutely, I agree. It certainly is an opportunity for us to call into question the fact that those other pieces of legislation were not considered in, together with the NHR bill as a solution. This is what we're proposing in these pieces of legislation, along with what's in the NHR bill, because you can't really see the full picture without those other pieces of legislation and what those proposed changes are.
So Finance Minister Enoch Godongwana delivered his medium-term budget policy statement last month. And I might be wrong, but I don't recall him mentioning NHI. And I specifically recall in an interview that you and I did on the CRA channel early in the year, in February, he didn't mention the NHI there as well. So do you think that Treasury is basically giving us a signal here that they're not interested in costing this? It certainly doesn't seem that the National Health Department is interested in costing it. So is this all just a bit of a fantasy, a bit of a holiday from reality?
We might consider the whole thing to be the detachment from reality, but maybe we'll go with holiday. That sounds better. But I mean, that's a fundamental point. That it's like I think the country's fast getting to the point now where everyone's realizing that there's no free lunch anywhere. We're under a massive amount of pressure. The financial situation is certainly not great. The economy is not doing well, and now we have a bill before Parliament in which what it costs is being completely ignored, almost as if it's of no consequence. And I mean, it's bizarre and extreme, let alone maybe we could even say irresponsible. And I think, what's rightly now is that the opposition is starting to say to the finance minister, to Treasury, listen, guys, where's the financial feasibility analysis on this? But that in itself brings another point, is that nowhere in the bill process does it actually talk about what the NHR is going to cover and what it's not going to cover. So how do you cost something if you don't know what you're going to be providing? I think the analogy might be you're building a car. So we're going to build this nice car, but we have no idea what the cost of the materials are or what the design costs are going to be. But we're definitely going to build it. Don't worry, and the cost will be irrelevant. It doesn't make any sense.
Right, and there's no guarantee that all of those parts will actually fit together and operate and move that car forward in the way that it's intended to.
Well, yeah, that would be a whole nother discussion. But I think, I wanted to just add there is that, so as a good example is Ireland. I think it was 2015. They put together their proposed universal health system. It's called, I can't remember what it was called, but it went through a sort of similar process of putting it up as a proposal. And then by the time it got to where it needed to be passed in legislature, the next step of their policy process was to cost it. And after that completed a very comprehensive costing analysis, they found this thing's going to cost them more than they can afford, and the policy was abandoned to say the country simply cannot afford it. A much more responsible process than to say we're just going to build it at all costs, regardless of what it's going to cost. Good example though for Ireland.
Yeah, and I remember the Davis Commission on Tax, the recommendation there, this was quite a few years ago now, pre-COVID. They were saying that economic growth would have to be well in excess of 3%. I mean, that's kind of assuming that you think NHI is a good idea, then it'll be implemented judiciously and transparently, which I don't think we think. But, even then, we're a long way off from that. The finance minister projecting economic growth at about 1.6% for the medium term, the next 3 years. So it just seems very pie in the sky to me.
Yeah, and I think what's worth noting, with all respect to Treasury, is that the economic forecasts, their growth forecasts for quite a number of years now, have always been quite optimistic. They forecast X, and generally always comes in about 0.5%, maybe even closer to 1% lower than that. So, and I mean, even at the projected number of 1.6, I mean, there's just simply no ways anywhere in the fiscus any amount of money can be found. I mean, specifically if we go down the route of implementing the basic income grant on a permanent basis going forward, I mean, that in itself is going to add a huge amount to government expenditure. So where there can be anything else for additional funding out of the NHR, I don't know, it's anyone's guess, but certainly I have absolutely no idea where that's going to come from.
Yeah, and we mentioned Dr. Nicholas Crisp earlier, and he was complaining about the lack of available funding for healthcare. But as you pointed out to my colleague in a recent interview on the CRA channel, that was Chris Hutton, between the year 2000 and the year 2021, the availability of healthcare funding has actually doubled in that period. And it's now about 6 or 7% of the total budget expenditure. So that's already a pretty significant allocation and on par with the amount of funding that other developed and emerging markets set aside for healthcare.
Yeah, I know it's a very significant point. I think that we need to assess is, one of the fundamental principles on which the policy process was argued that there was insufficient funding. Some of the comments from Zweli Mkhize, who was the previous health minister. I mean, he was categorically made a statement to Parliament that the reason that there were insufficient doctors in the public health sector is because the public sector budget hadn't increased in real terms for 10 years, but it's categorically incorrect. For the past 20 years, in real terms, in real per capita terms, the budget now is more than double what it was 20 years ago. So we've taken into account population growth, we've taken into account inflation. The public health spend, just public health spend, is double what it was 20 years ago. So, and that's resulted in also an increase in the number of staff employed by public sector. The number of filled posts has grown very substantially in the last 15, 16 years. There's a Treasury publication that they put out in 2017 showing it in preceding 10 years. So from 2006 to 2016, the number of filled medical posts, not administrative posts, medical posts increased by 43%. It's way in excess of what the population growth was for that period. So, and whilst I don't say that that's an absolutely sufficient number to run a first-class health system and give everybody the best amount of healthcare, we should at least in that period and up until now seen an improvement in health outcomes, an improvement in the quality of facilities, the quality of outcomes, but we're absolutely not seeing that. I mean, virtually on a daily basis, somewhere in the press, you'll find some statement about some, complete disaster in the health sector, in the public health sector. So the resource argument is fallacious. It is as simple as that. It just simply isn't true. The resources have increased. At the very least, we should be doing much better than we were 10, 15 years ago, but we're simply not.
Yeah, I mean, just a personal anecdote. I was having a picnic with some friends of mine, one of whom is a doctor, and she was telling me that the quality of nursing in the hospital, the public hospital where she works, is just so abysmal. At one point, a nurse called her during the night shift to say, this patient is gasping for breath and you must come quickly. So she rushed down there and found the patient had already died. And rigor mortis had set in. And now it takes more than an hour for rigor mortis to set in. So clearly this nurse was misrepresenting what was happening, had neglected this patient, and then was trying to pin the blame on this doctor. And, this doctor kind of gave me a back of the envelope figure. She's like 1 in every 4,000 nurses is pretty decent. But the rest aren't particularly good. So you can have a large number of bodies servicing the health system. But how well trained are those people? How capable are they? How committed are they? Are they held accountable for their mistakes? Are they rewarded for good performance? It doesn't seem like any of that characterizes the current public system. And I would say the hold of Nahawu is probably quite strong in terms of the grip that it has on the public sector.
Yeah, I think I was recently on a panel talk around the public sector health. I mean, my sense of it, there were a few stakeholders, including government officials from the Department of Health and the unions, and there's quite a lot of antagonism between the two of them. One sort of blaming the other quite openly and categorically for all the problems. I do think that the one danger we need to avoid, and because I think this is exceptionally, it's very unfair to label all public sector, with individuals, providers working, an enormous amount of people who absolutely do their utmost best. But it's the governance frameworks that have collapsed. It's the lack of accountability, an issue that gets virtually no airtime, but it has been highlighted by a number of both NGOs and academics, is the extent of moonlighting that takes place. This is where government officials or public health officials some years ago were given what's called the REWAP system, the remunerative work outside of public service, which is an official position that all medical personnel can perform a certain level of work outside of the public sector. So when they go into the private sector or anywhere else, and they get paid for that outside of that. But it's limited to the maximum amount, which is a small percentage of the overall work hours. But the evidence is showing that this become endemic, and it's happening now on a wide scale where people are being paid by the state a salary, but spending most of their time working outside the state in elsewhere. Now, exactly how big this problem is, we don't know, because there's not really any sort of official analysis or understanding of it. But even at the scale that it is being reported, it must be at least a significant problem that is then causing these failures to say, well, supposedly we've got so many nurses in the system or so many doctors, but they're not physically actually there. So, but surely that at least warrants some feasibility assessment or some investigation on the part of government to say, how big is this problem, and what's it contributing to the problems in the public sector?
Yeah, I mean, my colleagues at the IR have been campaigning quite hard against NHI, and one of the metaphors they use is that NHI will be the ESCOM of healthcare, and I think it's actually a very appropriate analogy, because I mean, here what you have is this attempt to create this huge monopoly over a very complex sector with lots of moving parts that requires very kind of careful integration. But when you overlay all of the kind of typical governance problems that are associated with state-owned enterprises, with the the misaligned incentives and the huge amounts of wastage that happens throughout supply chains, you can very quickly have a disastrous situation on your hands.
Yeah, well, absolutely, and I mean, it actually brings to mind. It was in the press. I think it was yesterday, or maybe the day before, that Ishmael Mamoniat, who was acting deputy DG in Treasury, has now been appointed as deputy DG. And he made a rather sort of blunt comment, but I think quite appropriate, to say that the problem with the deeply entrenched corruption in the state is that many times budgets are simply spent, or not spent on what they should be spent on, but they're simply stolen, if you like, before they go anywhere near service delivery. And I mean, we see numerous examples in the Department of Health of these problems. I mean, the horrific assassination last year of Babita Deokaram, where she uncovered 850 million rands worth of was flagged as suspicious payments, but that's from one hospital in a short space of time. 850, it's nearly R1 billion we're talking. I mean, that is not small change. We are talking a huge amount of money. Now, assuming all that money was, is lost to the system, in other words, it didn't buy anything that would be used in the. I mean, one of the items that we bought was jeans, denims. I mean, not quite sure where those get used inside a public health system, but those are the types of things that we see the evidence of all the time. Corruption Watch, which watches, obviously all in terms of that, has flagged numerous cases inside the Department of Health, and that these must be having an effect on service delivery. If money is going elsewhere, where it should be spent on consumables, remembering that health systems need a huge amount of materials, medicines, equipment, maintenance of equipment, maintenance of buildings. So it's not just personnel. It's not like an HR system, like say, where most money is spent on actual personnel. There's a lot of other things that are required as well. Well, that's where service failures will definitely happen if the money is just simply not there that should be there, for those services, for those additional items, medicines, materials, etc.
Yeah, I mean, I think the parallels also with ESCOM there, in terms of, if you think of Medupi and Kusile, these kind of mega projects, these big silver bullet solutions that are going to once and for all solve the systemic problems. NHI, is kind of the same, but I think it's foolish to think that it's going to actually magically solve some of the very complex problems throughout the system. But Mike, I wanted to bring us more to the present week. We're recording on Wednesday, and this week there's been some news about the certificate of need. So that, I think, is worth delving into a bit. Could you explain what those are, and also what this recent court case has been about, with the necessary disclaimers that neither of us are lawyers, but we'll do our best to represent what's happened.
Yeah, so I mean, well, I mean, we do consult with lawyers to sort of give us the background and the meat of it, where we may miss on those things. So the history around the certificate of need is that it was introduced within the National Health Act, which was passed many years ago in 2004. But it covers 4 sections in that act, 36 to 40, if my memory serves me correctly. But they needed supporting regulations to enable those portions of the act. And they were attempted to, about 10 years ago, to be put in. There was a lot of resistance to them. They didn't come in. And then I think another time, and then more recently, they were I think published at the end of 2021, somewhere around there. These are the regulations that were needed to now enable that portion of the act. So that portion of the act sat in abeyance, if you like. It wasn't really active for that for all the time since 2004. But the certificate of need provisions, I mean, what they dictate was complete and total control of doctors, and medical private medical facilities, hospitals, clinics, everything. Draconian at the lightest description. Doctors would have to apply, where they could work. The state would be able to tell them under what conditions or what facilities they could open, but even down to the point of what medical equipment they could purchase to place in their medical facility. I mean, one of the provisions of the certificate of need said that the DG of the Department of Health could issue a certificate of need based on any condition that they deemed fit to put in there. So hardly constitutional. It was Solidarity plus ASAIPA. It's an association of independent practitioner associations who represent doctors, and a few others who jointly went to court on this this year in June. The case was heard. The High Court judge ruled that it completely unconstitutional, not on just 1 or 2 counts, but on 6 counts. The interesting thing about that is that the case was unopposed. The state had been sent the notice of the application. The applicant's attorneys had sent notices to the state attorney, to the DG, the Minister of Health, the presidency even, to say, are you filing papers to oppose this? And nothing happened. So the case went unopposed. Now the state has attempted to rescind the application. This is the court case that happened yesterday. But what the High Court has ruled is that the Constitutional Court needs to determine whether the original ruling from June is ratified or not, in which case the state could appeal. It appears that they could appeal, although there's some question marks from some of the legal people to say that it's not quite sure that they are entitled to appeal. But anyway, the point about it is that the High Court judge in June this year, it was a fairly scathing report in terms of the constitutionality of the certificate of need. And that is fundamental to making the NHI work. If those aren't in place, the NHI proposal cannot proceed as it's envisaged. Well, because you won't be able to tell doctors where to go, what to do, how to do it. The major provision, as far as the private sector is concerned, is the one ruling from the judge was that you cannot take away current healthcare access and in supposed argument that you're going to give it elsewhere because it's not progressive, that's regressive. So her argument was Constitution requires progressive realization for everybody. You can't take away, you can't rob Peter to pay Paul and say that that's meeting the constitutional obligations. Outside of the fact that for the most part, private healthcare is paid for by the individuals. It's private money, not tax-funded money. So that in itself is another issue altogether we look at. But that would then mean if that ruling is upheld, it would mean that the NHI could not dictate to medical schemes to say, you cannot insure what's in the NHI fund, based on what the judge ruled in the June 2022 ruling. And if the Concord ratifies that, I think it's pretty much end of the road for this. As the NHI proposal stands, I think it's pretty much end of the road. But I think it's still got a long way to go, so we'll have to see.
Okay, well, that's very interesting. I mean, I suppose even if the bill itself was implemented, there could be a separate legal challenge to that. But yeah, it's good to see that this fairly technical element is also being challenged. So how do you see this particular case playing out, and what are your kind of estimations and predictions?
Yeah, look, I mean, these things are always difficult. I mean, could be so many scenarios playing out. I mean, I think we need France Grenier or Clem Santa to help us here on about 4 or 5 different scenarios. But yeah, for what it's worth from our side, I think if the certificate of need or the rulings from the June 2022 court case are upheld, it's going to be very difficult to proceed as the bill stands now. I think in and of itself, there are a number of concerns around the way the bill's been implemented. The governance framework is exceptionally weak, gives it a lot of power, almost complete autocratic power to the Minister of Health, that position, if you like. So no matter who occupies it, the current health minister or future health minister is going to give a lot of power. So I think those are major concerns. And I think from what I hear from a lot of other NGOs, stakeholders, that they're going to certainly go all the way to fight this, simply because there are so many issues with how this thing has been put together, and is not going to achieve its stated aim. I think that's probably the key issue. Is that and I think this is a fundamental issue. There's a lot of criticism has been levied that it's just the private sector whinging and moaning that everything's going to change for them, but it's not. It's going to change the public sector fundamentally. Remembering that both private and public institutions will require accreditation to deliver services under NHR, and that accreditation will come from the Office of Health Standards Compliance. As it stands today, the 3 reports that the Office of Health Standards have completed of inspecting public facilities, no more than 15% qualify or get accredited. So how do you run a national health system if only 15% of your facilities don't meet accreditation in order to partake? The focus should be, how do we get these facilities now operationally functional, that they comply with these health standards? Anyway, just that's, it's a key point there as well, I think. There's so many points around this thing. We probably spend 3 hours talking about this, but that in itself is another lack of rationality of this process. How do you propose to do that if you don't have facilities that are accredited by your own standards? You're saying that everyone must be accredited, but if they can't and they're not, then what do you do?
I mean, that's ultimately what we're looking to solve, right? Is how do we improve the quality and access to healthcare in South Africa? I mean, fingers are often pointed at the private sector for being too expensive. But if you think of prescribed minimum benefits that are imposed on private health funders, they have to cost those in, right? So that prevents them from offering low-cost competitive products to the poor or aspirant emergent middle-class customers. So that's a huge latent block of customers who could potentially be served quite adequately by the private healthcare sector, and private funders would have a lot to gain from that.
Yeah, and they may have something to gain from it. I think the key issue here is that the PMB legislation under the private sector and the medical schemes under the Medical Schemes Act is just inappropriate for a country like South Africa as a developing economy. It would be great if we were a wealthy first world country. There would be nothing wrong with the act as it is now, because everyone would be able to afford that level of cover. But they can't. I mean, in real terms, the participation in medical scheme membership has been declining. It's only actually ironically been bolstered by very significant subsidies that are given to state employees for membership of GEMS, the government employees medical scheme. But outside of that, the medical scheme membership today would be much lower than what that is. So we need a private health framework that is suitable to the country in terms of its affordability levels. I think that the implementation of the low-cost benefit options, which have been on the table now for years, I think if I remember, it started in 2004. So we're looking nearly 20 years, and it's been on and off the table, I think, at least 3 times. And each time it's sort of pushed aside because it's from political decisions rather than practical decisions. An expanding private sector is a fundamental to getting a universal health framework in 95% of countries. There are very few countries that have gone the NHR route, and the NHR route is a go-it-alone route. The state assumes all responsibility for healthcare for everybody. And the countries that have done that, or like Britain, Canada, these are first world countries. The other two are, I think, Latvia and Estonia. I can't remember exactly, but the only developing economy has done it is Cuba. But the system in of itself has all its other problems in terms of its human rights issues, and also cost. The Cuba spends more than 11% of GDP on public health, which just emphasizes the issue around monopolized, centralized systems. They're not efficient. They're expensive. And if you consider in the Cuban example that they pay their doctors absolute peanuts, it's like taxi drivers in Cuba make more money than doctors do. The fact that the expenditure sits at 11% is a wonder. It truly is. But that's the route that the NHR model wants to follow. It's been categorically stated.
Yeah, and a lot of people on the left often point to Cuba as an example of a universal healthcare system that is really laudable. But what you just described sounds terribly inefficient and not very effective. Even in the United Kingdom, which is a wealthy country, it's a bit taboo to talk about it. But there's some huge problems with the NHS system, and one of them is access to kind of longer term care, like say if you need a knee replacement or something like that. I think the emergency care is still pretty good. And I remember breaking my finger when I was in London and going in and getting it fixed quite quickly. But that was a relatively minor thing. But if you've got some longer term complicated syndrome or something, then it can be quite bad. And it's the same with the Canadian system. You hear all sorts of horror stories from there. People fleeing over the border to try and get care in the United States, even if it costs them to do so.
Yeah. So, I mean, I think, I think in Britain, if you try and change the NHS, you might as well immigrate because you're going to get lynched. It's a national treasure that nobody wants to change. Yeah. It's got strong support. I do think it's a relatively good system. I mean, it does have inefficiencies around being a monopoly. But I think one thing that Britain's done well, and I think we could learn from that, is that when you heavily centralize the management of functionality in health systems, that's where all the inefficiencies creep in. Now, NHS is often lauded as this big centralized national health system, but it's anything but today. It has been completely decentralized. This process started in the late 80s, in which Britain fundamentally realized that the centralized control process, how it had been implemented. Remember, it was built in 1948 is where it kicked off. And I mean, the clear thinking in those days, it was much more social, more central control, those sorts of aspects. But today, the NHS is nothing like that. It doesn't operate on the centralized basis. It is quite decentralized. Members have choice in it. And that's improved the NHS over the last 30 years. Outcomes have improved. It's got better. It's still not great by other OECD countries, if you look at like Germany or the Netherlands or such, but it's a very good example to look at, to realize that this heavy centralization of all facets, like the NHS is proposing, does not work. Even in where public service administration like the UK is orders of magnitude better than what it is here, it still doesn't work well there. So this idea of centralization will give benefits of cost and better efficiency. The evidence is just not there for it.
Yeah, I often say that you should craft policy with the state that you have, not the state that you wish you had. I mean, we don't have British or Korean levels of civil servants. We have South African civil servants who are not particularly strong, unfortunately. But yeah, even in the UK example, I mean, you are seeing companies like Vitality actually doing pretty well there and mushrooming of private healthcare providers.
Yeah, no, I mean, I think the point from our side is that if you marshal all the assets in a country, from a healthcare perspective, private and public, and you also add into the mix the willingness for people to purchase their own private care, as happens now in South Africa, that alleviates pressure on the state, because the more people are in private, the less pressure is on the less, and people want to buy their own private healthcare. It's not there's a sense that it's expensive. It is a great purchase, but for many people, they want that better access. They want that improved care. And, so the equity argument comes up to go, but it's unfair. But, people are purchasing it with their own private money. If you want to take that argument down to every level in society, then you become a complete communist state where there's absolutely no private sector. Everything's everything's equal, everything's run by the state and provided for you. And we all know where that ends up. It just doesn't work. And people are worse off in those systems. They've all failed. It's, to be honest about it. So, so, I mean, I think that looking at it from that point of view, it'd be much better with it outside of that ideological thinking.
And obviously, it's a very emotive topic, and there's a lot of moral connotations to it because we're dealing with issues of life and death. I mean, ultimately, it is the provision of a service and people buying that service, right? So, the state is not providing soap for me, but I value soap. It's something that I go out and buy from a pharmacy or a supermarket, and I keep myself clean because that's a healthy thing to do. Same with brushing my teeth. But, healthcare is something that most people do care about and are willing to pay a premium for if they have access to those resources. I guess the question is, what do you do with people who are less advantaged in our society? How do you get them healthcare as well?
Yeah. I think it's the point around that, and I think this is a key issue that I'd like to try and emphasize, is that it's created as a moral argument in South Africa now that because the private sector spends a lot of money on healthcare, that's why the public sector is in a bad state. That's just simply, there's no evidence to support that whatsoever. I mean, the state within its resources that it has should be doing much better. So that to me is a scapegoat argument to say that because there's lots spent in the private sector that that's why the public sector is in a mess. It's simply not true.
Yeah, consumers are voting with their feet in that regard.
Sorry, I was just wondering, at a point, it'd be like arguing in a much simpler sort of analysis. It'd be like saying that because the private security industry exists, so it employs, a huge amount of people. That's why the police services are in a mess. So, should we go and nationalize all the private security firms and amalgamate them into the police service, and then we'll have wonderful policing services? I mean, anyone who would believe that, you go, no, no one would believe it. I mean, maybe some would believe it, but certainly no right-thinking person could possibly believe it. But that is exactly the proposal that is being put on the table with NHI. Exactly the proposal.
Yeah, I hate to break it to you, Mike, but there has been legislation in South Africa looking to localize security. So I'm afraid it's not as an absurd an example as you think it might. I think one concern that I have is the flight of skilled medical practitioners away from South Africa if NHI is implemented, if these certificates of need are implemented as well. So are you equally concerned about that risk?
I think it's a huge risk. I think it was SAMA and Solidarity did their own separate surveys of their members and doctors, and what would they do? It was I think it was around a 40% number said that if NHI comes in, they're gone, they're out. There's like an emphatic statement. I mean, medical doctor shortages are not unique to South Africa as a global issue. So, there's mobility amongst medical professions. So I mean, a good example of this, going back to Cuba again, was when they nationalized their health services in the 70s. I think it was the 70s. It was quite a long time ago. And this is before Cuba sort of had, closed borders and everything. A third of Cuba's doctors left the country within a year of the nationalization of the health system. And their health outcomes plummeted and stayed low for more than 10 years. It took them to recover because they now just simply didn't have enough doctors. And this is another criticism, I would say, of the NHI policy process. It hasn't even considered that as an option. Do doctors leave en masse? And then what do we do? Why has that not been considered? So yeah, I mean, it is an absolute risk, and I think a very probable one.
Well, it's interesting that Solidarity and others have polled people, but it doesn't seem that the Department of Health has polled their own medical practitioners to see how they might respond to NHI.
Maybe get some interesting outcomes from that too. Who knows?
Right. Well, Mike, I just wanted to give you this opportunity to maybe inform the public about what work you're doing with the FMF in the health policy unit to try and push back against NHI.
Yeah, that's a good opportunity. Thanks. I mean, I chair the health policy unit, so that's it's obviously a unit within the Free Market Foundation. And what we try and do there is sort of have a look at health policy, try and consider what's workable, what's not workable, evidence against other countries, what's worked there and what would potentially be better here. I mean, some of the things are quite obvious, but don't want to be considered. I would dare, go to say that, it's very obvious in the public sector that the governance, the lack of governance, for the destruction of the governance frameworks, the lack of accountability, those are much more key issues than funding levels. The private sector, we've got the health market inquiry there, that evidence is there that we can go around down that road and fix that. So these are the types of things we try and highlight as policy recommendations, if you like, from our side. I mean, obviously it does involve, sometimes being, quite critical of it. But for stakeholders, it's a platform that potentially, participation could happen if there's belief in what we're doing is the right way. So yeah, we invite stakeholders to contact us, and potentially we could look at bringing them on board, taking in their views, and we would then be able to put those out as a considered policy position.
Well, yeah, I would certainly echo that call. But Mike, something that has struck me is that a lot of the big kind of corporate healthcare funders, the big insurance companies, and so on, they seem a bit equivocal on NHI. They seem to kind of be saying, well, we're engaging constructively with government on this, not really coming out with a full-throated objection. Why do you think that is, and how could we change that?
Look, I think it's a particular position that probably most industries take, is they don't want to be overly critical. They want to rather have working relations with, in many cases, they're regulated by government, so they don't want to have these sort of acrimonious relationships. So I think maybe it's a sense of, we rather work through with negotiation and engagement, and that sort of position, to rather sort of see an evolution of policy. But having said that, I mean, there has been some criticism from big players in the private sector. Some have been quite equivocal. Others have been much more subtle and much more diplomatic, if you like. But the private sector must be concerned. I mean, they cannot possibly be comfortable with where things are standing now, as it is. Maybe they believe that, because of the state of the economy, there's no way this thing's going to happen. So that might be a position they're taking, and therefore there's nothing to really worry about. I don't know. So it's difficult to tell.
Yeah, well, I think what's quite important in some of these debates is that you draw some hard lines. My concern is that we maybe get some watered down version of NHI, but still the fundamental problems remain. So kind of arriving at some kind of compromise or consensus position could actually be worse.
Yeah, I mean, I think, if I were to add to my point to that, I think that given the economy and where we are, I think as they want to implement it, it's very unlikely they're going to be able to do that. So in a sense, I would support the thought that the private sector probably doesn't have terribly much to worry about in terms of that. Well, that could still cause some particular problems there. And I think that's a failing from our side to project that kind of view that it's only about the private sector. It's not. This is fundamentally ignoring all the problems that exist in the public sector. And that's where 85% of South Africans access their healthcare is in the public sector. And it's disastrous at the moment. I mean, it should be doing much, much better. So the key issue is not just opposing what NHI is, to say that why are we not focusing on getting the fundamentals right in the public sector? Why is the governance not being addressed? Why is the corruption not being addressed? Why is the moonlighting not being addressed? Where's the accountability in the system? Because with the resources we have, we can compare with other countries and know that we should be doing much better than we are, but we're not. So I think the sort of part from NGOs like ourselves is that the issue must be not just that we're protecting private sector interests. We're actually saying that things should be better across the board, and that they should be better. And that's a position that we want to be quite clear on.
Mike Settas, thank you very much for sharing your solutions with us.
Thank you very much for having me on, David. Appreciate it.
If you enjoyed this conversation and you're watching on YouTube, please do give this video a like and subscribe to the channel. Also, let me know your thoughts down in the comments section. Do you think that NHI represents a risk to South Africa's healthcare system? Also, a quick note that I will be pausing the podcast in December. I'm going to be taking a bit of a break and also evaluating what I want to do with this platform in my new role. My name is David Ansara. This is the Solutions Podcast. Until next time, take care.